Hello everyone, my name's Louise Brown. I work in the translation and education area of Jean Hales, and together with support from the Victorian State Government, we're really excited to present our third webinar for 2016 tonight. Firstly, can I start by acknowledging the traditional owners of the land that we're meeting on tonight and the lands we're reaching, and pay respects to elders past, present and future. For those of you who don't know, Jean Hales for Women's Health is a national not-for-profit organisation. We're dedicated to improving the knowledge of women's health by combining research, education and clinical care and practical education for women and for health professionals. So we've had 400 registrations for tonight's webinar, and I'm sure there's lots of you online at the moment all around Australia. If you want to type in where you are, you can do that in the chat box or type in the Ask a Question down on the bottom right hand side. So tonight our focus is endometriosis and diagnosis and management. We know that endometriosis is the most common cause of pelvic pain experienced by women, and up to 10% or 1 in every 10 women has endometriosis. And for many, the path to diagnosis is actually quite long, and it can be a 7 to 10 year wait before a woman actually is diagnosed with endometriosis. So this delay is one of the reasons why we're so keen to talk about the condition tonight, and to try and shorten that delay for women so they're not experiencing the symptoms that go with endometriosis for such a long time unmanaged. We'd really like to raise awareness of the condition, dispel some of the myths around period pain, extreme period pain being normal, and we'd also like to help health professionals identify some of the signs and symptoms that might help women along that path to diagnosis a bit faster. The area of our website, the Jean Hales website, the endometriosis pages are the most frequently visited of all our health information pages. So it tells you that the need for knowledge is out there, and I think tonight is a step on the way to improving that. We're going to use the chat box, as I said, down the bottom, so the Ask a Question. We have had a lot of questions prior to the webcast already come in. But pop some in there tonight. If you've already asked it, don't ask it again. We already have it online, and we'll try and get back to you after the event if we don't cover everything tonight. Hopefully you've had a look at the pre-reading. There were some fantastic articles that we sent you, and they're a good thing to refer back to that cover a whole lot of areas of endometriosis. And you should have received the slides this morning so that you can take notes if you like. Once the webinar closes, you won't be able to download the documents, but there are documents somewhere on the panel that you can download. So the slides are there, the speaker bios, and another resource which we'll talk about a little bit later. Don't forget, if you want to receive points or CPD points for the RSCGP program or other certificates for your CPD course requirements, you need to complete the evaluation at the end of the webinar. So once the webcast finished, it will take you to the evaluation page, and you can complete it there. So you will receive a link once the webcast is in our webinar library. You'll get a link later in the week or early next week, and you can watch the recorded version. So tonight I'd like to introduce the speakers so we can get on with the important business. I won't read their bios, they're available if you'd like to read them. Dr. Jim Saltis, who was one of our speakers, was unable to be here tonight. He's had a family illness, a serious family illness, and we've been really lucky that we've had Dr. Melissa Cameron step into the void. We're very grateful. At the 11th hour, she made herself available, so we're really pleased to have her along. And we've also got Dr. Janine Mainwaring and Dr. Mandy Deeks, so they're part of our Jean Hales clinical team. So we're going to start with each panellist delivering some key points. Then we're going to watch a video of a patient named Jo, so talk about her experience, which I think is a really important part, hearing the voice of the patient and how they live with endometriosis or their experience of it. And then we're going to look at a case study. So I think that's probably enough from me. We'll have some questions, hopefully have some time for questions at the end, but that depends how we go during the night. So let's get down to the important business, and I'll introduce you to Melissa Cameron.
Thank you very much, Louise, and welcome everyone to the webinar tonight. So tonight I'll be talking a little bit about the basics of endometriosis, going through some of the epidemiology, some of the pathogenesis and the theories we have surrounding endometriosis, and also how it affects patients from regards symptoms, but also from an infertility perspective as well. So endometriosis, we only have an estimate as to how many people have endometriosis because the diagnosis can be sometimes difficult and only truly achieved by laparoscopy. We really have estimates that about 7 to 10% of women have endometriosis in the general population. If you look at a population of infertile women, so women have been trying to get pregnant but haven't managed to conceive, up to 50% of them will be found to have endometriosis to some degree. Certainly it's very common in women with pelvic pain. 70 to 85% of women with chronic pelvic pain will have endometriosis. There appears to be no particular racial disposition, although there is a familial association, and certainly if a patient does have a family history of endometriosis, so mum, sister, aunties and so on, they will have an increased risk of endometriosis, even up to 10 times increased if there's a first degree relative who's affected. As far as how endometriosis occurs, to be honest, we don't know for sure. There are a lot of theories. The most popular theory being that of Sampson, where is the theory of retrograde menstruation. So this is a phenomenon where some of the menses will go backwards through the fallopian tubes and into the pelvis during menses. Now this happens to about 90% of women, we think, so it's very much a common physiological thing that can happen. But when that happens, certainly you end up with some endometrial tissue, some lining of the uterus going into the pelvis. And in some women it appears that this isn't cleared. And certainly we know women with heavier periods are certainly more likely to have endometriosis, possibly because they're getting a heavier load of endometrium and blood going into the pelvis each month. There are also theories that it can spread by the blood or by the lymphatics, and we certainly often can see endometriosis at sites distant to the pelvis, so in the umbilicus quite commonly, even up near the liver. There are some reports of patients having endometriosis involving the lungs or involving the nose as well. So we think in those situations it's probably spread either by the blood or by lymphatics as well. Coelomic metaplasia is that when the lining of the pelvis actually spontaneously develops into endometriosis cells as well. With regards to the surgery we do see endometriosis in women who have had, say for instance, caesarean sections. It's not that uncommon to find endometriosis in caesarean section scars, so the scars on the abdomen. Also the port sites, so people who've had laparoscopies, at times you can find a recurrence of endometriosis, particularly in the umbilicus or in some of the lateral ports that we use as well. And I've mentioned before the predisposition if you have a family member that's affected. So obviously there's some genetic involvement there, particularly if we think of retrograde menstruation. 90% of women have that happen to them each month, but not 90% of women have endometriosis. So there's obviously some genetic predisposition. At the moment there's no particular gene or set of genes that has been identified, even looking in familial studies, but certainly this is an area to watch. It's a rapidly expanding area in medicine. As far as symptoms, endometriosis makes its own rules. If you had 10 patients with endometriosis, they'd all have different experiences. And I think this is one of the things that makes it very difficult when you're trying to diagnose it and trying to triage who you refer and who goes on to have more extensive investigations. There will be a certain number of patients who are asymptomatic, and so the endometriosis is found at times where they're being operated on for other reasons, such as for having their tubal ligation done, for instance, and it's something that hasn't come to the fore before. Most of the women that have endometriosis will have some experience of dysmenorrhea, so pain with their periods, around about 90% of women. And usually this is quite cyclical pain, so it occurs either just before or with the onset of menses and tends to taper off near the end of menses. But there's a lot of variability in this, and some women this will develop even into a chronic pain picture where it's not just associated with menses, but they're getting it throughout other times of the month as well. And often if you historically ask patients, particularly those with very severe endometriosis, if you historically ask them, what have your periods been like? Sometimes they'll give a story of, yes, I've always had painful periods, it's got worse, was just with my periods, but now I'm getting it all the time. And sometimes that's an indicator that the disease has progressed so far that it's not just affected by periods. Deep dyspareunia, so pain deep inside when patients have sex, that can sometimes be an indication of pouch of Douglas disease, so disease in the little cul-de-sac behind the uterus, between the rectum and the uterus. I find a lot of women, they often complain of this deep lower back pain and ache and feel the feeling that their organs almost are falling out, and a lot of women who have that will have uterosacral ligament disease. As said before, endometriosis can certainly affect other areas of the pelvis, in particular the bladder and the bowel. So some women will get dysuria and pain as their bladder fills up, or pain when they're holding on to their bladder, more than what you'd expect as normal. In very severe situations where endometriosis is going through the wall of the bladder, you can get problems with hematuria, although this is less common. With regards bowel involvement, a lot of women will experience a degree of bowel dysfunction with their periods, most commonly constipation leading up to their periods and some diarrhoea once their period starts. But if you explore this further and ask about actually pain when passing bowel motions, blood when passing bowel motions, there will be a degree of some women that have problems with endometriosis actually growing into the bowel. And infertility in itself can be a symptom as well. As far as infertility, as I mentioned before, up to 50% of infertile women, if investigated, will be found to have endometriosis. And we think there's many ways in which endometriosis can affect fertility. Firstly, it can damage the tubes directly and physically cause anatomical changes so that the tube and the ovary aren't in close contact and egg and sperm actually can't meet. But also it's a very inflammatory process, endometriosis. It creates probably quite a toxic environment for eggs and sperm. So I think this probably can damage the eggs and sperm, but also damage the embryos and impair implantation. We mentioned also adenomyosis, which is like a cousin of endometriosis. It's where some of the lining of the uterus is growing inside the wall of the uterus. It can be, again, difficult to diagnose, but we often see this in conjunction with endometriosis, and it's not uncommon for women with that condition to have problems with fertility as well. So certainly that's something to consider investigating if you've got a woman presenting with infertility. So that's my part of the talk this evening. I'm now going to hand over to my colleague Dr. Janine Manwaring, who's going to address endometriosis in younger women in particular.
Thanks, Melissa, and thank you to Louise and to be part of this important webinar. I'm talking about endometriosis in younger women and about the initial evaluation and management of women and adolescents presenting to their primary practitioner. So with regards to endometriosis, that the number of years that it takes to come up with the actual diagnosis from first symptoms, it comes up again and again as somewhere between 7 and 10 years, and that this has a very big impact on women's symptoms and functioning both through their life and then also from potential with fertility as well. And so looking at the reasons why this might be, that there are probably several. There is a belief that period pain is normal, and that can be either within individuals or within cultures where women are residing. And there's also a common belief, and that is not necessarily factual, that their symptoms may improve with pregnancy. There is a belief that endometriosis is a disease of older women, and so that if a younger woman is presenting with very significant pain, that couldn't be endometriosis, but the endometriosis can actually be present from menarche or rarely even before. So it needs to be considered. The symptoms can be very non-specific. They can overlap with other diagnoses. There can be a lot of bowel symptoms with periods, but also with endometriosis, like Melissa touched on. There can be non-cyclical and atypical pain symptoms in between periods, which are more common in younger women. So that classical dysmenorrhea picture may not be actually what is being told to you. The physical examination is often normal, and if it's a young woman who's not sexually active, then it'll be just a transabdominal rather than a transvaginal examination, and often an abdominal examination is completely normal. There is no non-invasive diagnostic test for endometriosis, and so to actually have the diagnosis you need to have a laparoscopy done. And so obviously that is invasive, it carries with it risks and concerns, and so we're often going on a suspected diagnosis and empiric management, but we need to have a plan for how to go forward with this if your empiric management isn't working. And then when it comes to the laparoscopic side of things, that young women's endometriosis can often have a very different appearance on the surgical picture compared to the classic sort of black burnt out looking lesions of endometriosis that you may have seen in pictures and textbooks. So you need to have someone who can recognise it to know what to biopsy, to what to treat. So as far as initially evaluating dysmenorrhea, really it all comes down to history. So you really need to have some key points, and I'll go through all of those shortly. It may be the only alert to the possibility of endometriosis as the cause of the symptoms that's brought the woman to you. A pain diary can be very useful, and to just be keeping a record of what's happening with the pain, if there's any cyclic changes within the symptoms, what sort of impact it's having with daily functioning. As I said, the examination's often normal, that investigations are often normal, and so that a pelvic ultrasound can potentially have some benefit if there is suspicion of any reproductive tract developmental anomalies, that it can demonstrate some of those. And but limitations, once again, especially if it's a transabdominal scan. So some key points: that endometriosis can occur anytime from menarche, and that the actual disease and its associated pain and symptoms are stimulated by hormones and fluctuation in those hormones and subsequent inflammation. And so when we're looking at addressing the symptoms, then we're looking at addressing the hormones and addressing the inflammation. So empiric medical therapy to reduce the inflammation and to hormonally suppress the menstruation is helpful because it treats the pain, it treats the inflammation, it can help to decrease early endometriosis. It may inhibit disease progression. We don't have a lot of evidence on the exact effect on disease progression because of the need to do an invasive test each time. Hormonal therapy can be used in adolescents after the menarche. So this is a very common question of how young is too young in terms of starting anything hormonal. When girls have had their first period, that they have reached about 98% of their adult height and their bone density. So usually they're not going to be presenting to you straight away. It would often be after 1 or 2 years. And so by that stage, starting them on any hormonal treatment will not be affecting their future height, and there's no evidence of problems with future fertility from being on hormonal treatment from early on. Really, failed medical therapy is an indication for referral for laparoscopy. Somewhere between 3 and 6 months you need to have enough time for it to have some effect, but especially in younger women, you don't want to be leaving it for too long in terms of impact on schooling. The laparoscopy should be performed by a surgeon who's experienced in recognising and treating endometriosis, and that really what we're hoping for with early diagnosis and treatment is that the pain can be treated, that there can be a return to a high level of functioning, and hopefully that future fertility can be preserved. So just with regards to the young patient, and some of this is going to be very challenging, especially if you are the family primary practitioner that you've known this young woman since she was a baby and she's been brought in as a teenager by her mother or caregiver, that you need to be interacting with her as your patient and not as that she's the child of the parent. And so you need to be very open. You need to explain that you will need to talk to the adolescent as well, or as the young woman as well as with the mother, but also separately, and so, or the caregiver. So that's introduced very early on, and that it's not that the young person is asking their parent to leave, but that you're taking responsibility for that, to take that discomfort potentially away from the equation. They're briefly talking about the style of questioning that can be helpful to look at addressing all aspects of the young person's physical and mental health. So some key questions to ask and some answers suggestive of possible endometriosis. So age at menarche, there is an association between endometriosis and a younger age of menarche. Ask about the pain. As Melissa said, that often the pain will start sometime after the periods and may progress with time, and that also what happens in terms of symptoms with regards to their cycles, but keeping in mind that they might be non-cyclical symptoms or symptoms between periods. To ask about where the pain is described in terms of location and severity. So there are high rates of adolescent dysmenorrhea reported, but most of them are reported as mild and manageable simple analgesia. So if the pain is being described as unbearable, significantly impacting on quality of life, not responding to treatment. Non-menstrual pain is very common in adolescents. So up to a quarter will have, that's up to a quarter with endometriosis, will have pain with bowels, with bladder, with often some bloating, some gut disturbance that can happen, that things that may be exacerbated with their periods but not necessarily. And then also, as far as some of the history and questions, to just know what treatments have been tried before and for how long and what has happened with that, so that you are appreciating what their journey has been so far, and really to be looking at what quality of life is, what impact the pain is having for them, because women with endometriosis do consistently show decreased quality of life scores. To find out about their fertility story and also about the family history. So I'll pass on to Mandy now.
Thank you, Janine. And thank you also. I'd like to acknowledge my thanks for this opportunity. This is a fabulous opportunity for us to present on endometriosis. And obviously very dear to my heart is the mental health. Looking at the research, we know that the impact of a diagnosis of endometriosis does show up as higher rates of mental illness. So it might be depression and anxiety. However, there's a path to that diagnosis, as we've already heard. And what we find is that path to diagnosis increases stress. It may actually be that there is pain associated with the symptoms of endometriosis, and it's a bit hard to work out which direction the pain actually results in the mental health problems. So it might be that the pain begins and anxiety and depression are a result after time, or a woman may already have been experiencing depression and or anxiety, and then the pain really exacerbates, and as Janine mentioned, the quality of life is compromised. And when we hear the stories of women with endometriosis and adolescents, we hear words like distress and hopelessness, and often women will talk about feeling isolated, incredibly frustrated, and there is a sense of feeling worthless, that the plans or perhaps the dreams that women might have had aren't necessarily going to play out how they thought it would. There's a lot of grief and loss associated with it. When we look at the factors that influence mental health and endometriosis, time to diagnosis consistently comes out. As Janine mentioned, the average time to diagnosis is around 7 to 8 years. And it's difficult because women don't necessarily seek help when they might need to, because they think that the period pain is normal. And then when they do present, or when they might talk with loved ones or friends, it's often dismissed as normal as well. So there's a period of time that women think it's just part of their lot and they don't seek help. And then when they do seek help, there are a lot of health professionals who also might think that that's normal and, you know, perhaps there's nothing wrong, that's just what's happening for you. So that can add to that feeling of frustration and sense of not having control or power. The literature really tells us that women who have symptoms are more likely to experience depression or anxiety, particularly pain. The uncertainty, so the variability of symptoms, the trial and error of different treatments is often very difficult, and just trying to make sense of it. What is this that has affected a woman's life? Daily functioning, so things like exercise, pain on intercourse is a big factor for a lot of women. We also know that sleep is often affected for women. Fertility, the research tells us that women who struggle with fertility have higher rates of depression, certainly. And relationships, intimate relationships, but also family and friends, and particularly with that familial history, it can often be other family members talking about their experience and almost dismissing a woman's experience herself. It might mean that women hide, or they struggle with their identity. Who am I, and what role was I going to play, and now what role am I going to play? There's also a cost. There's an economic cost to a lot of women that really is quite distressing, and a productivity cost. It might be that we know that women tend to lose about 19 days a year from work if they have endometriosis, but there's also that lack of concentration and fogginess and fatigue that comes with it. So if you add in stress and fear, adversity, anticipation and anxiety, that's likely to all be affected as well and reduce quality of life. Screening is vital. So I've just popped in a couple of questions that if you could ask these questions of any woman who is diagnosed with endometriosis or on that path and really struggling with pain, that's a fabulous place to start. So if women have often been bothered by feeling down, depressed or hopeless, often been bothered by having little interest or pleasure in doing things, or been bothered by feeling excessively worried or concerned, they're just three really high-level questions that might sift out a woman who might be on the path to depression or anxiety. So any yeses to those requires further exploration. Management in terms of mental health is very much around having a diagnosis and then the treatment. That will go a long way. Information, we are about to launch some fabulous new resources at Jean Hales, a health professional tool, a booklet for women, and also a pain and period diary, as well as a brochure for women anywhere from adolescence right through life. I think supportive relationships really are vital, and that might be friends, it might be family, it could be a support group. Understanding and having someone who actually listens is vital to emotional health. Adaptive coping strategies, so you know what's right for each woman, and just asking women what are their coping strategies, what's working, what has worked for you in the past. Denial, reaching for substance are definitely not the coping strategies that are going to help. Pain, because pain is such a significant part of endometriosis, perhaps some cognitive behavioural therapy for pain, or maybe some exposure therapy. Mindfulness has been shown in the research to be very effective, and SNRIs have also helped with pain, not so much the SSRIs, but that's a very individual conversation with each woman. And because of the painful intercourse, some interventions and some understanding and some help, perhaps with different aspects of dyspareunia, is also really important.
Now we're going to watch a video and hear from Jo. So just to give us a sense of what a woman with endometriosis is managing in between her visits to you, I think it's an important thing to keep in mind. So we'll hear from Jo and I'll ask the panel to comment after. So Jo, just tell me, what was your experience of your menstrual cycle as a young woman?
I first got my period when I was 12. By the time I was 14, I would have been taking 8 to 10 Panadol every 2 hours or so for the first few days of my cycle to control pain. I changed high schools for year 11 and 12 and was much happier at my new high school, and that was really the first time that I realised that there was a link between my emotional happiness and my menstrual cycle and pain. When laparoscopic came on the market, it was like an absolute blessing because I could manage any pain with that quite successfully, as I had a feeling that much Panadol was really not very good for me.
So did you ever see the GP about your period pain, or...?
I switched GPs when I was 16 when we moved. It was a lovely bloke, but again a bloke, and I don't think that was really something I at 16 felt comfortable talking to him about. And then I had a female GP from my late teens, early 20s onwards, but it actually never occurred to me to discuss it with my GP. I was on the pills until I was 24, so they were certainly managed with that. By my mid-20s to 30, was managing it with naproxenic from a pain point of view, but I also had no idea what flow was normal, and it's only later looking back that I realised that all the signs were still there.
You had heavy flow, I'm taking it?
Yeah. And again, it was I didn't understand that 15 to 20 super tampons per cycle was perhaps more than normal. Had no idea.
And no one had mentioned that, and because you hadn't talked about it with a GP, you didn't actually have that information?
No, not at all.
So when did someone first mention endometriosis to you?
It only really came out after I had a laparoscopy, a diagnostic laparoscopy for fertility issues when I was 36. So it turned out I had severe endometriosis, which she treated while she was there. But yeah, I was 36 by the time that happened. So.
And possibly had endometriosis for some time.
Yeah, in hindsight, you look back over your medical history and think, yeah, probably at least since I was 13 or 14.
So do you think, or can you tell me, do you think the endometriosis has had an effect on your quality of life?
Yes, I'd give that a qualified yes. Certainly I've never let it stop me from doing anything. It just means some of the doing might have been harder than you'd like. There's the days when you're dragging yourself along, the days when you get your period on a Saturday or Sunday and you're just so grateful because you can just spend 2 days in bed rather than using every shred of energy to get you through your workday. You
last year started to have gastrointestinal problems.
Yeah.
So just step us through that if you can.
It's kind of minimising it to say I had a bowel resection. It's more how I got to that surgery in the first place. So last year I had 5 discrete episodes of what I like to refer to as vomiting marathons, between 6 to 8 hours, 15 to 20 minutes apart, always at night. And after the third occasion, I thought, this is not a food hygiene issue. I think there might be, something else going on. When the fourth one happened, I thought, best I go and see my GP. And then the fifth one happened only a month later. So I had myself off to start the medical rounds then. Mentioned to every specialist that I saw that at least 3 of the 5 episodes had happened on day 2 of my cycle. Always talked through my medical history in terms of endometriosis and adenomyosis, which was diagnosed after the second laparoscopy I had. And there was no pick-up from our specialists along those lines that there may have been any endometriosis involvement. After a number of tests and scans, they found some small masses at the bottom of my small intestine, and it's the masses that they presumed would be tumours and therefore led to the recommendation of a bowel resection. I was the one that asked for the gynaecologist to be present for the surgery, remembering something that my obstetrician had said, a decade or so ago, about having, potential bowel involvement. And subsequently, when I had my follow-up with him, there had been endometriosis on both ovaries, which was ablated, burnt, and the endo that was in my pelvic cavity was excised. And it was only after 6 days after surgery that the pathology confirmed that the 2 areas which the rectocollar surgeon had to remove were in fact endometriosis was through and along the bowel.
And since that time, you've said that your gastrointestinal function.
Oh, it's extraordinary. My quality of life is better than has been in 11 years. My digestion is now completely back to where it was 11 years ago. It's just fantastic. I feel so great.
Tell me, when you were first diagnosed with endometriosis in your 30s, what was the reaction of family to the diagnosis?
Yeah, predominantly was with my mum, because it gave us a view back to her medical history and my grandmother's medical history. But it's highly probable that mum had endometriosis based on, a number of facts, including she was on the pill in the 60s, fell pregnant the minute she went off the pill with me, and she had multiple miscarriages after me, sadly, and ended up having a radical hysterectomy when she was 36 from fibroids. My grandmother is not the kind of person who would ever discuss such things. But she was married at 21 and had her first child 10 years later, which I think in between 1929 and 1939 was quite unusual. And then my uncle was born 5 years later, at the end of World War II. So again, it's hard to know. It's not the kind of thing she would have ever discussed. But when you look at the facts and the culture of the time, it wouldn't surprise me at all.
Tell me about endometriosis and its impact on your intimate relationships.
Yeah, so the lead up to the first laparoscopy was also trying to conceive, not successfully. You're watching your calendar, you're watching your ovulation times. There's enough out there that people know that can affect your intimate relationships as well, just the stress of trying to conceive. It was only after the first laparoscopy and the successful one that I realised that in fact sex was painful. It was only when it stopped being painful that I realised that it had, and that's what I think is one of the really insidious things about endometriosis is the constant rebaselining of what your normal is. And it's only when you have a significant event like a surgery that you go, oh, actually, that was really bad. That's not normal at all. But it's been such a slow decline that your body's recalibrating what's normal all the way along the line.
I'm quite interested to hear whether Jo's story is a common story. Mel, would you like to comment?
Yeah, I think Jo's story has a lot of things that are very common to a lot of women who experience endometriosis, but particularly in her early adolescent years, not really knowing what was normal and what wasn't normal, not necessarily having anyone to talk to or any reference to base that on. I think often, that's one of the great advantages of nights like tonight, is that education is so important, and for people to become aware of what's normal. And hopefully now with society, we do talk about these things more often. There is more information available for patients to get an understanding of where they fit, and so therefore they may access access their GPs and healthcare professionals earlier. But also the delay in diagnosis. I think we've said that several times this evening, that it happens a lot, and it's often in these women's most sort of productive years. So it's in teenage times, school times, the stress of year 12, setting themselves up in their career, doing further study and so on. In early relationships, maintaining those, there are a lot of stresses that can certainly be affected, and I think her story has a lot of typical things in it.
Yeah, I thought Jo's very health literate. She's quite assertive. She was able to ensure that the second specialist was there at her surgery, and I just think a lot of people are not in that same position as Jo, and it was really fortuitous that she did think, despite the fact that people knew her diagnosis of endometriosis, there seemed to be a real lack of awareness that these bowel symptoms could actually be related to her endometriosis, and it was only her putting the two and two together that she suddenly thought, wow, I should actually have a gynaecologist at that surgery. So that sort of worries me in a way, that there is this lack of understanding in the health professional world that endo has these other side symptoms, I guess. So it was just, it was really Jo that got that happening.
Yeah, and I think unfortunately sometimes with gynaecology, we do exist a little bit on our own little island. And most women will have some sort of gynaecology issue, or certainly their gynaecology is relevant to nearly any medical presentation they have, and certainly should be asked about. But it often falls off the radar a bit in specialties outside of our specialty, particularly when you're looking at other specialties.
Yeah. So this whole idea of raising awareness of endometriosis is part of the plan, part of the grand plan. So now we're going to move on to our case study. So we're going to look at Peter. Peter's a 16-year-old girl attending the GP for advice regarding her period pain. She's brought in by her mother Judy, and I think this is quite a common story. The mother's concerned about the impact that the pain's having on Peter's schoolwork and her outside activities. So, Janine.
So we'll walk through the history and this scenario of Peter, initially early presentation and then about how she progresses through life. So Peter is a 16-year-old Year 11 student that she's been fit and well with no health issues through her life, that went through a menarche at 12 with a normal development. Periods became regular and painful from when she was 14. Her cycle is regular. She doesn't have particularly heavy menses, but she has got severe pain across her lower abdomen and her lower back during her period, occasionally severe enough that she vomits or faints. She often has headaches during this time as well. And then on further questioning that unrelated to her period, she has these stabbing pains in her abdomen, that she has some uncomfortable bloating. It's not related to her periods. It goes up to about a 4 or 5 out of 10 compared to her period pain that she says is more like an 8 out of 10. She has tried some paracetamol, but she prefers to not take medication and will take some time off school, off her usual activities, will stay in bed with a heat pack, and often will miss 1 or 2 days of school, and also her morning swimming training. And significant worries to her and her mother is that Judy had terrible periods and endometriosis was discovered later on, and so she's very concerned that this could be happening with her daughter. So remembering that the history is the most important part of eliciting the story of each individual woman, and it may really be your only key to things being outside of normal. A general history regarding the gynecological symptoms, and then also the bladder, the bowel, sort of considering what else goes on inside the pelvis, as well as a holistic assessment of the individual. So regarding periods, not particularly heavy, she doesn't have any abnormal bleeding, never been sexually active, although you could save this question until you're talking to her without her mother in the room. Doesn't have any acne, hirsutism, no bladder problems. Her bowels do get erratic around the time of her period, but as Melissa talked about earlier on, that a lot of women will get bowel symptoms around the time of their period, and that doesn't necessarily indicate that there is any significant endometriosis involving bowel, but she does get quite a lot of bloating and stabbing pains that can happen any time throughout her cycle. She doesn't have any concerning symptoms with regards to weight, appetite. She is exercising less because she's missing her swimming training from pain and fatigue. She's not sleeping that well. She is doing well at school, but she has quite a lot of stress given that she's in Year 11, that she's missing some schoolwork, and she's worried about how she's going to manage with the VCE. So now is a good time to reiterate to Peter's mum that you'd like to have a chat to her on your own, and so you basically say, okay, now mum's gone, let's have a chat. Is there anything else that's on your mind? So she can say, my God, mum's really bothering me because she keeps talking about her endometriosis all the time, and I'm annoyed about that, but I'm also quite worried because I know she had a bad time in operations, and so I don't want that to happen to me. She tells you that she wants to do very well at VCE and go to uni, but she's very stressed about how she's going to manage the schoolwork, about her sick days. She can't she can't catch up on missed work because she's so tired. She doesn't think she's depressed. She does swim regularly. She's not in a relationship at the moment. She's never been sexually active. She has spoken with friends about period issues, about the pill. She's really not very keen on the pill because she's heard from people that it can cause health problems and fertility problems. She doesn't smoke or use recreational drugs. She does have occasional drinks at parties. So with regards to diagnosing endometriosis, as we said earlier, a pain diary can be very useful just for getting more than one snapshot in time about what's happening with symptoms and how they're impacting her life. Briefly covering with these slides, listing the differential diagnoses, just to run through a symptom review and to consider what other things might be impacting. With regards to examination, physical examination is very frequently normal, as I said earlier on, and if the girl is VI, so Virgo intacta, or never sexually active, a pelvic examination is inappropriate. But even if you do one, it may be completely unremarkable. With regards to investigations, it's important to check that she isn't pregnant to make sure she doesn't have any acute or chronic inflammatory processes going on, that she doesn't have a urine infection or a chlamydia infection. With regards to other investigations, with regards to CA125 or other blood markers, urine markers, endometrial markers for endometriosis, nothing has been shown to have a good enough pickup rate to differentiate it from anything else. So there is no benefit in organising any other screening markers at this stage. An ultrasound is reasonable to rule out a reproductive tract anomaly. If there is a concern about an ovarian cyst or a torsion, if there's concern about appendicitis. Ultrasounds can be very good at detecting endometriomas, but these are actually very rare in young women. They're often not present until the early to mid-20s. And also, and very importantly, a negative ultrasound does not exclude the diagnosis of endometriosis. So it's not essential, and it's something to consider. So with regards to the next steps, as I said, so you've examined her, you've done some basic investigations, you've talked about pain diary. You talk with Peter and also with Judy about some concerns around pain and impact on potential functioning with the potential diagnosis, and we'll touch on that. Mandy's discussed that a bit already, and we'll touch on that as we're working through Peter's story. Now, to discuss empiric treatment, so there'll be more detail in the slides that you're having to read later on, but with regards to empiric treatment, they're not just about masking the symptoms, they're about treating the underlying issues with inflammation and with the hormonal fluctuation that can add to the symptoms and the disease. So the anti-inflammatories help with the inflammation that's around, and they will help with the pain, and the hormonal therapy will help to relieve cyclical symptoms, and it can also be used for menstrual suppression. They will be helpful with the majority of young women, and if there is successful empiric management, that there's not any evidence that this will cause an issue as far as delaying diagnosis of significant endometriosis, and there's no evidence that endometriosis will progress because you've treated them medically rather than go straight to a laparoscopy. So the empiric treatment is detailed more. I won't run through the entire slide in the interest of time, but this talks about how these two main classes can work with the anti-inflammatories and also with hormonal manipulation, that either combined oral contraceptive pills, so estrogen and progesterone, that leads to treatment of the endometriosis tissue, or there's progesterone only progestogens, and I'll go through, they'll be listed a little bit later on. There's not been any one treatment that's been shown to be of superior treatment and results compared to any other, that it's certainly a question that has come up time and time again about which pill do I use, is it okay to use a combination of different things to achieve amenorrhea, and there isn't a clear answer. And yes, it is okay to use more than one thing at a time, that we often will add in an extra progestogen, or consider even using an implanon with a pill or an implanon with a Mirena to achieve amenorrhea and to achieve a symptom control from pain. So initial management for Peter, that she decides that she will use regular anti-inflammatories over the next month and keep a symptom diary. So comes back with her mum and says, look, things are a bit better, maybe period pain 5 or 6 out of 10 rather than 8 out of 10, and I've only missed 1 day of school but 3 swimming sessions, and not really a lot better with regards to the pain in between. And so with some further discussion, that the decision is to say, okay, well, let's go on to a combined pill and use the regular anti-inflammatories and see how that goes over the next 3 months. So Mandy, do you want to make any comment at this stage about where you'd approach things from the psychological point of view, the stress that she's feeling?
Mm-hmm. I think, and you mentioned the mother's role in it, and how perhaps she was almost traumatising in her response. I think it's good to tease out some of those issues, and I think we also know that the sooner you do talk about it and sort of not do an intervention, but perhaps release some of the thoughts and help with stress management, the better you are long term. I think also giving the information, the education, reassuring, normalising, saying there actually is a path that we can take. I think a lot of young girls in particular, when they might get the diagnosis, fear, well, I'm never going to be able to have a baby. Or so having that conversation with Peter early is a really nice way to handle some of the things you might be able to stop later on, and reducing the influence of mum a little bit as well. Yeah,
because it's a very common scenario, as I'm sure that all of you experience, is that you're dealing with, especially with younger women, you're dealing with 2 separate patients really,
Yes.
and that you need to be addressing both concerns, and that they may not actually be the same concern.
And I think the other point I make to patients is that you, as mum, you had this happen 20 years ago or 16 years ago in this case, potentially. Medicine's changed a lot. This is a very rapid area of research. Techniques for treatment have changed, laparoscopic techniques have changed and improved. So what our 4 women have been through isn't necessarily what she's going to experience, even if she does have endometriosis and need treatment.
Would it be a time to actually talk to the mother without the daughter present, to actually tell her to keep a lid on it? This is just a question. I don't know whether that's the right thing or not.
Yeah, I certainly do. I can think of a very recent situation where I did have to take the mother inside and explain to her that she wasn't the patient in this scenario, and that potentially she was damaging, causing more damage or difficulty. Yeah. So I think it's very relevant to do that.
Yeah, good.
Yeah. But clearly not something you're going to be able to tease out in a 15-minute appointment. So a benefit of having that longitudinal relationship with the individual, with the family, but that also presents some tricky situations as well.
Yeah, and I don't know, I'm sure this is something that we've all heard and experienced, but the mother can actually have very strong opinions about what treatment they believe is right, and therefore influence the daughter, and then that stops a possible treatment that would actually have resolved something earlier as well. Yeah. So that's part of that trauma response, and actually reducing and understanding what the reality is. So I think we've talked about the pill, and perhaps some mothers don't feel comfortable with their daughters going on the pill, particularly that whole whether they are sexually active, and why would you go on it if you aren't sexually active, and does that mean she is? So,
or that she will be.
Or that she will be.
And then there's the cultural nuances too to consider, isn't there, depending on the culture of the people that you're working with.
Yeah. So a lot of potential for some further education and discussion points Louise will mention, but certainly available through the Gene House website as well for both younger women but families to raise points of discussion and openness and what's normal, and to just help with a lot of these trickier issues. So Peter comes back after 3 months and still things aren't great. She's had some improvement that she pretty much bled all the time over the first 2 months of the pill with some very erratic pain, but she's had no bleeding in the last month, and she has had a bit of improvement with some of her episodic pain, but so because she's not menstruating in the last month, she hasn't had any dysmenorrhea. Her stress level is still considerable, but she's thinking that she'll push on with this plan, that she'll look into some alternative treatment with some relaxation. So 3 months later, it's now January, Year 12 starting. Pain really hasn't made a big improvement, that despite being amenorrheic on the continuous pill, that she's still having this episodic cramping pain up to 6 out of 10 at least once a week. Because she's on the pill and not bleeding, she doesn't know when this is going to happen, which makes it a bit harder to control with anti-inflammatories. She didn't do as well in her exams as she hoped. She's very worried about how this is going to spell out through Year 12. And so discussion and decision is made that you've had a reasonable go at some decent medical treatment and time for a laparoscopy. So with regards to surgical management, it's another very common question about when and who and how early is too early, and that is that there isn't a stage where it's too early, but it's just important that you've had a good appreciation of what's been happening with symptom-wise and a good trial of medical treatment before anybody has an operation, because it is the gold standard for diagnosis with a laparoscopy, but laparoscopy has its own risks. It's still an operation. It has minor complications in about 3%, but there is a major complication rate of about 1 in 1,000, and that there are concerns with repeated operations, that you can have more issues down the track with scarring and with pain. And so really we need to be looking at targeting surgery for people who have tried medical treatment or who have symptoms that are suggesting that there may be more significant disease going on. And sadly also is that the severity of the symptoms does not correlate with the stage of the disease. So it can mean that there's a bit of head scratching going on, but it's important to really be aware of what's happening, to talk to and listen to the patient, talk to colleagues, and then to refer to specialists for further assistance. So surgery has been shown to reduce pain, but you need someone who can detect the lesions and treat them at the same time. And then going on after surgery with postoperative medical therapy is also very important, because this has been shown to reduce pain, to prolong time between operations in the future if they're required. It potentially can also improve fertility and has been shown to improve quality of life. So at laparoscopy, there's Peter's pelvis on the left, it showing some endometriosis through the uterosacral ligaments bilaterally, as Melissa had talked earlier on, that pain that's in reproduced in behind the uterus and under the ovaries. And then there's the picture of surgical excision. And so it was diagnosed, resected from throughout the pelvis, and she's returned to school, had an uneventful recovery. So key points with the post-operative management: it's important to discuss it and to continue it, and that there are several options available. There's some mention through that Louise will cover as well about the potential for alternative complementary natural therapies, and also there can be a benefit looking into lifestyle, diet, regular exercise, healthy lifestyle basically, and to keep the conversation and the review about treatment that she's on, about what's happening with activities, about what's happening with regards to her changing plans as she progresses, with regards to being on the pill, whether fertility is coming up as a potential concern. just briefly, as I mentioned before, about people asking about the pill and if there was any particular one that is better than others, and no, there isn't, but also to take into consideration side effects and cost. So you follow up with Peter and she continues on the continuous pill. She's happy, she's pain-free, her bowel symptoms have resolved, she's doing well at school. She is still stressed, she is stressed about now what does it mean for the future with regards to endometriosis, but she's looking back on track pretty well. There's a flow chart there that I won't go through now, but just talking about the steps towards diagnosis. And now I'll hand on to Melissa for the next part of Peter's journey.
Thank you, Janine. So Peter's come back now. She's now 33 years old, so we're 20 odd years, not quite. Not very good at maths. 17 more years down the track. She's now been trying to get pregnant for 9 months now. And the one thing I would mention, it's not just her trying to get pregnant. Presumably her and a partner have been trying to get pregnant. She's still having regular cycles. She is having some pain with her periods, and this pain is quite debilitating. So obviously the pain's got worse over the last preceding 17 years. She's getting some sex pain, some deep sex pain, and also some pain when she's using her bowels. And just on the mentioning the fact that it's two people trying to get pregnant, certainly in this scenario, it's important to evaluate both members of the couple and not isolate one. I think as women, we take a lot of responsibility for reproductive health, both not getting pregnant, but also getting pregnant. And I think it's really important to involve the partner, certainly in this process. So as far as investigations that you would do, certainly a semen analysis, so a sperm test is certainly warranted, I think, at the 9-month mark. The other thing I would mention is, she has only been trying for 9 months to get pregnant. Generally speaking, we would think about investigating at 12 months, but in her situation, there's already been a bit of a red flag waved that we know she's had a past history of endometriosis, we know this disease can come back, she's got some recurrence in some of her symptoms. So I certainly think it's worthwhile assessing her when she presents and taking her concerns seriously. I'm sure, Mandy, you could attest to the stresses of fertility treatment or fertility investigations and not wanting to get pregnant. And we mentioned before that this was a concern of hers 17 years ago, and that may have been bumbling behind in the background over those preceding 17 years. So certainly I would take her request to be investigated or her presenting at this age with her history as a very serious one and go ahead and investigate her. So arrange for a sperm analysis for a partner. AMH is anti-Müllerian hormone, which is a measure of ovarian reserve. You may or may not want to do that as a primary health practitioner. It is a very highly anxiety-provoking test. Of all the tests I order, this is the one I get the phone calls about, people wanting to know their result. It is a measure of the reserve in the ovaries. It's not an exact egg number. More importantly, it doesn't give us any idea of quality of the eggs at all. But certainly if it's something you're happy ordering, then you could think about doing that. At day 21 or a luteal phase bloods, really you're looking at progesterone to confirm that you have ovulation occurring. You'd certainly want to know how regular her periods are, what her timing has been like as far as intercourse goes. I'd routinely order a thyroid function test to make sure there's no thyroid dysfunction and a transvaginal ultrasound. Certainly with her history, and we know she's had endometriosis in the past, I would be trying to find an ultrasound service that's experienced in women's health ultrasound. In addition to these investigations, you could initiate just general pre-pregnancy investigations, make sure she's up to date with pap smears, has had a breast check and is on some folic acid as well. In some situations, you may also consider preconceptual genetic screening as well. So Peter's gone on and had her ultrasound, and unfortunately it's shown that she's got what's called an endometrioma. So this is an endometriosis cyst, so it's a collection of endometrial fluid. So essentially a collection of old blood. These cysts have a very typical appearance on ultrasound. It's one of the few cysts that most ultrasound services will diagnose with a fair degree of confidence. As you can see from the ultrasound here, it has what we call a ground glass appearance, so it's a very homogeneous appearing ovary. This shows her right ovary, and it's quite a large lesion. It's around about 4 centimetres, and this could certainly be affecting her fertility. On that particular ultrasound, it's very difficult to see any normal ovarian tissue, any follicular activity in that ovary, so it's probably having a suppressive effect. And the thing with endometriomas, even if there is some concern about the diagnosis and someone's unsure of the diagnosis, endometriomas don't tend to get better by themselves. They don't tend to regress at all. So, and also they don't tend to get bigger quickly. So one of the things you could do is repeat the ultrasound in a number of weeks to confirm the diagnosis. But certainly a diagnosis of something such as an endometrioma in the situation where she's wanting to get pregnant certainly warrants referral to a specialist. So how do endometriomas, and we did touch on briefly before how endometriosis affects fertility. Endometriomas do release a lot of inflammatory mediators, and these inflammatory mediators can be quite toxic and start killing off all the primordial germ cells and the primordial follicles, and so deplete the egg number. And certainly if you were going ahead and doing IVF in a patient like this, you are likely to get a low response and the ovary not respond well, as well as increasing the surgical risk of having her eggs collected. This is a laparoscopic photo of an endometrioma. So in the top of the screen at about 12 o'clock is the uterus. The big white things you can see are the ovaries. The one on the left-hand side of the screen is a big endometrioma, and as you can see, it's about the same size as the uterus, so it's probably around 5 to 6 centimetres big, and the left side also has an endometrioma as well. It's difficult to see. You can see on the right there is the fallopian tube. It's very difficult to see on the left side, but all of the normal ovarian tissue is very much stretched over that endometrioma, so you're not going to get as much follicular activity happening as what you would in a normal ovary. And usually this is something that we would certainly consider treating, and even just treatment of this alone, so treating it laparoscopically may improve her fertility chances. At the same time as doing that procedure, you could certainly go ahead, look inside her uterus, check her fallopian tubes and check for tubal patency as well. So the sort of issues we consider when faced with a patient with fertility and the potential of endometriosis is, when do we operate? Generally speaking, if someone has a past history of endometriosis and a recurrence of their symptoms and they haven't got pregnant, that's usually a fairly good indication to do an operation. Unfortunately, a lot of the medical management you use for endometriosis is also going to inhibit pregnancy because most of it's hormonally based, and looking at stopping ovulation, so obviously it also has a contraceptive effect as well. As far as what we do, we're going to approach these laparoscopically nowadays. We do have very good laparoscopic equipment. We're very fortunate in Australia that we do have many people who have experience in endometriosis, and certainly trainees coming through the program, their laparoscopic skills are far above, even when I went through the training program, which wasn't that long ago. So mostly we'll be doing laparoscopic surgery with the aim to preserve their fertility and improve their fertility as much as possible. One of the difficulties we've got, particularly with endometriomas, I'll just flick back to it, is the nature of treating that cyst. An endometrioma usually has a whole heap of fluid inside the cyst. You let that fluid cyst out, but then there's kind of a skin or a wall of the cyst that you need to get out. And inevitably, when we treat that, we do take a bit of normal ovarian tissue with us. So we're a bit between a rock and a hard place with treatment, because she's already has impaired ovarian function, but the nature of the treatment is also going to further impair her ovarian function. And certainly, one of the risks I always discuss with patients in this scenario is it's a small chance, but obviously a very important chance of losing the ovary during the surgery. As far as conception after the surgery, it really, the main thing in this patient situation at an age of 33, so this is a fantastic age. I certainly wouldn't want her to be coming back in 5 years' time with this problem, because then you have the problem with endometriosis and reduced ovarian function, but also the quality of the eggs very much declining. I usually do AMHs before and after these operations in these patients, just to get an idea of where they are from an ovarian reserve point of view. As far as IVF, when would IVF be the next step? It depends on several factors. There's many ways to get pregnant, particularly when you're thinking about fertility treatments. It depends on what a partner's sperm like certainly if he had a significant sperm abnormality and she's got significant endometriosis, IVF might be the next appropriate step for them and the most appropriate step to maximise their chances of conception. But if otherwise, if his sperm analysis was good and she had a good result from the surgery and you're sure that her tubes are patent, you could give her a chance to try and conceive by herself. You know, again, I wouldn't say off you go for a couple of years. Usually I'd review patients every 6 months and touch base, see where they are with things, see how they're coping with the emotions of trying to get pregnant and what do they want as a couple, where do they want to go ahead with things as well. So that sort of concludes the presentation so far. I'll hand back over to you, Louise.
Yeah, I just was going to follow up on that. Just in terms of having endometriosis, does that bring down your level of sort of watch and wait in terms of fertility? So normally,
yes,
okay,
absolutely. It would personally. That's how I'd practice, but that's how most people would practice because we do know that it will affect fertility.
Yep. Okay. And what percentage of women with endometriosis go on to have assisted reproductive technology?
Oh, look, that's really difficult to answer that question. It's easier to look backwards and look at women who are infertile and who need treatment or who end up having endometriosis, and up to 50% of them will have endometriosis. A lot of it depends on age as well. There's often multiple factors, not just the endometriosis alone. You know, certainly if you're a young woman with endometriosis that's been treated, you've got a very good chance of getting pregnant without any assisted conception. As soon as you introduce other factors such as smoking, age, being overweight, sperm factors, then all of that makes it much harder and you're more likely to need some sort of intervention.
Okay. Well, that's great. We're on time. We have time for questions, which is excellent. We've had some questions come in. I noticed there's a question around approaching getting the mother out of the room during the consultation, but Janine actually did talk about that early in her introduction slide. So if you want to go back to those slides, she does talk about telling the patient that it's a normal process for the patient to be excused from the mother to be excused from the room, and introducing that early on.
Yeah, to introduce that early on. But certainly, much easier for me as a specialist where I don't have that long-term relationship where, and I'm sure as a lot of you will do, that you've had that long-term relationship, potentially even having had delivered this baby girl who's now the 16-year-old in front of you, or you've known the family for a long time, and then all of a sudden you're addressing her as, you know, as a young adult. And so there's some difficulties around that, but I think really saying, okay, well, you've brought your daughter here, and to be directing questions to the daughter, not the mother, to introduce early that it's your practice with any patient, including young patients, that you have the possibility of talking to them on their own to develop that patient-doctor relationship that you haven't had with this young person before. But if you think any other sort of strategies to approach, but potentially very, very tricky.
Very tricky. I think that last point that you made about this is an opportunity for you to develop a relationship with the daughter, and I think a lot of mothers actually feel, okay, it's probably reassuring them that you're not going to go in there and talk about, you know, sex and contraception and all of those things without them being in the room, but it's really about, you know, your daughter's growing older. This is a fabulous time for us to get a special relationship going, and to do that we just might need to have a bit of a chat, the two of us together. We can talk with you afterwards if we feel that that's something, you know, that we want to touch base with you
as long
about.
as the daughter said it's okay.
Exactly.
And I think that's a really important point, is confidentiality.
Yep.
Like Janine, I set the ground rules early. I introduce myself. This is who I am. This is how I run the consultation. So everyone's on the same page. But emphasising confidentiality to the daughter and sticking with it. And, you know, I have a lot of parents ring me up wanting information, and I won't. And it might be as simple as changing an appointment. But I think once you've initiated that relationship with the young woman, then you need to maintain that and stick by what your rules are.
Definitely.
So in terms of just having talked about the mental health aspect, Mandy, and the impact of endometriosis on women's mental health, what are some of the supportive interventions? One of the GPs has asked, you know, what can they do as a primary care practitioner to support women with endometriosis?
I think the first one is information and education. So, but it's the right kind of information and education. There's a lot of information in Google land that might not really be evidence-based or trusted. So it's about getting the right information. And I think even that we find a lot of the time people will say to us, we print a lot of our resources, but what health professionals will say is it's lovely to be able to hand a gift to a patient as they walk out the door. So first off, having that at your fingertips, so having that information. It is about that relationship too, that trust, and then feeling that you can ask any question. Or but we also, I guess, depends where we are on the continuum of diagnosis, and whether are we at the painful periods and sorting that out, and it really does depend on where we're at and what relationship we have, and time. Time is so limited in a consultation, so what do you deal with and what's the priority?
I know there are some support groups here in Melbourne for women with endometriosis, and they may exist in other cities as well. I'm not sure about that, but I guess that sort of thing, that peer support sometimes can be useful. Sometimes it's a double-sided coin.
It depends on the relationship with the GP, the time that you have, the other supports that they might know you have in your life, and it might be that the support group is the place. Some women actually don't want to go near a support group, but then it could be counselling. It could be just a couple of sessions. It doesn't have to be ongoing. It might be allaying some of the fears. You talked, Melissa, around this is often a very vulnerable time for a lot of, you know, they might be doing VCE and they lose a bit of their confidence and their identity and think, well, I now have this condition, or I'm really struggling, and what's that going to mean? So the unknown future, that raises the stress. I was thinking as we were talking, you know, about the different things that Peter was going through. It's almost like this cycle. She got through, and she actually managed to get through her VCE, but then the next thing comes along that she's thinking about, and that raises the stress in a different way. So it's where someone is in the cycle, and then thinking about the different stress managements. Mindfulness is another really good, just to calm down. Identity, talking about what roles are, and counselling can be incredibly helpful, but doesn't need to be ongoing forever. And
there may be school counselling. If it's a young woman at school, there may be access to a counsellor at school.
Yeah, often women will talk about feeling, and girls feeling guilty, like they're letting their team down, or they're letting their parents down, or other people work, and that then adds to that cycle. So it's about an understanding work environment as well. And
Jo talked about that in her. Maybe that didn't end up in the video, but she did talk about working in a male-dominated environment and how that was really challenging for her, because she definitely didn't want to come up to work and say, "Oh, I've got terrible period pain," because she worked with 30 blokes.
Yes.
You know,
so either work in your favour or not. That's just on a practical level with teenagers in school, is you can be really important in liaising with the school and facilitating, special consideration, or obviously with the patient's consent, just letting them know this is a real medical issue. It's not just a little bit of period pain. They are significantly affected by it. It does affect concentration. It does affect their ability to perform in an exam environment. So I think we have an important role to help support them through that as well.
We've had a question, and previously as well, it's quite a common one. Both Jo in her video and Peter in the case study were experiencing painful sex or dyspareunia. So pelvic floor physio obviously is something that would be part of this management?
Yeah, definitely. I mean, there's several aspects that can sort of play into painful sex experiences, and obviously something that once again can't be dealt with in a few minutes with a consultation either, but endometriosis, it can be the physical presence of endometriosis, and so surgery can relieve some of that. It can be the hormonal side of things, and so some medical treatment can help that. Sometimes it can be muscle spasm that's developed as secondary to pain and then can become a pain generator itself, and so that is very common. And pelvic floor physiotherapists that have an interest in pain are just gold when it comes to helping with this. And so you may know of pelvic floor physiotherapists in your area, or certainly in Australia through the Continence Foundation of Australia, that they've got on their website their physiotherapists who are all having to be properly certified in pelvic floor physio training, and they're listed by region, and so throughout Australia you can find someone, and that is someone that can have an ongoing incredibly therapeutic benefit with pain with sex, but also within sort of exercise management and with general well-being.
And I think it's something to address early as well. Don't be afraid to ask about sex. They may not volunteer that, but it's one of these things that tends to snowball over time, and then you get sort of other pathologies happening as well.
And I think with all of those things that women may be very perhaps slow or reticent to bring it up, but certainly when it's asked in a straightforward, so a lot of women have pain with sex. Are you having any trouble with pain with any of these things? And that once it's brought up and it's sort of on the table, then women often with this big sigh of relief, and they're like, I haven't told anyone about this for years because I've been too embarrassed, or I thought it was me,
they wouldn't
or
initiate
I thought it was normal.
Thought it was normal, And so then that is opening up a whole potential of benefit from a quality of life point of view, and also helping with fertility point of view.
Just got a question here about the role of GnRH analogues and danazol in the treatment, and can GPs prescribe these?
Yes, within that flow chart that I had previously, and in the information, the pre-reading you were given, they're mentioned. GPs are able to prescribe any of these. Personally, I never prescribe danazol because the androgenic side effects, the masculinising side effects, are hideous. The GnRH analogues basically providing a medical temporary menopause, but along with that go the side effects of menopause, including the risks of bone density loss. Certainly not appropriate for use with adolescents, not appropriate for prolonged use without considering some form of hormone add back to help counter the osteoporosis risk. So it is something that does get used, but it really on a GP level is probably getting complex. There is a newish agent, Visan, that's on, so a Dynagest, it's on the market in Australia now over the last sort of 6 months or so. It's expensive, it's up to about $80 a month. It has been shown to be as effective as GnRH analogues at managing symptoms without any of the menopausal side effects. But if you look at the data, using a continuous pill versus GnRH analogues in terms of symptom control is actually the same.
So that actually feeds into
and much cheaper.
A question that a GP, Melinda, has asked: if there's uncertainty regarding the diagnosis, i.e. primary dysmenorrhea or endometriosis, and you start the combined pill, should you prescribe continuous?
Well, when you're on the pill, there's really no reason to have a period. So, I mean, it's the sugar pills were only put in to replicate a monthly cycle in order to help convince women to take it if they were worried that skipping a period was unnatural. So, physiologically, there's no reason to take sugar pills. And just to run the pill continuously, there's no evidence that that's going to do any harm with any health aspect, and in fact looking at long-term pill users, there's often health benefits, but also there's some data on using the pill in 3 monthly blocks, tricycling, but there's longer and longer preparations being used overseas, and so I talk to people about taking the pill continuously from the beginning. Sometimes the first month or two, if they're with the breakthrough bleeding, that having sort of 2 cyclical months just to help it sort of settle in, but then to be looking at running it continuously.
Okay. And a question for you, Mel. So medications for symptom management when a woman's trying to fall pregnant.
Yeah, this can be really quite tricky, particularly in the women with very severe endometriosis, where you've done as much surgically as you can. Often, part of the problem when someone's trying to get pregnant is you really can't use a lot of the hormone treatments. You're certainly not going to use your GnRH analogues because they're going to inhibit ovulation. So you're really back looking at simple analgesics, so either non-steroidal use, but saying that if you're using non-steroidals chronically, you're inhibiting your prostaglandins. Prostaglandins are really important for implantation of an embryo, so you can cut those ones out. So really you're looking at paracetamol and opiates, so not ideal, but this is where certainly if someone's got significant endometriosis symptoms still, you'd be thinking about surgical management. The difficulty is if, particularly with adenomyosis, which is involving the uterus, being a relative of endometriosis, that can be very difficult to control just with simple analgesia, and really you need the hormonal treatment, but that's not going to be able to be used if someone's trying to conceive.
We're going to have to wrap it up. I just have a couple of things to say at the end. Perhaps just one last question, which I will also address to you, Melissa, is about the specialist imaging and what can GPs be requesting when they're doing some investigation?
Yeah, look, I think this area in ultrasound it's expanded rapidly. It's really exciting what they can see on ultrasound now. And I think we're very blessed in Victoria. We are absolutely awash with specialist women's imaging centres. So people have done training in obstetrics and gynae and have gone on to do further training in ultrasound. And we do have a lot of people here with a specific interest in endometriosis, and particularly early endometriosis and what signs they might see on ultrasound. So the sort of information that might be useful for you as a practitioner is you want to know about the uterus, its size, its shape. You want to know about the muscle layer of the uterus. Do they think there's adenomyosis? Is it tender when they have the ultrasound done? Traditionally, a lot of vaginal ultrasounds are done and they look at the uterus and the tubes and ovaries. They don't look behind the uterus, which is where most endometriosis is. So if you're writing on your request slip that you're worrying about endometriosis, are there any areas of tenderness? Are there tender uterosacral ligaments is emerging as a bit of a marker of endometriosis. So I think certainly use your ultrasound colleagues to your advantage, and push them, ask them for what you want, and then hopefully you'll start getting the information. And certainly they are being educated as to all the benefits of what we can find out with ultrasound. Even though we can't get a definite diagnosis, sometimes it can be a very helpful triage tool.
And it doesn't have to be, it doesn't have to be a specialist ultrasound for that this can be your usual ultrasound provider, and providing them with clinical details can be a huge difference, but then also having that dialogue with them in smaller communities to say, look, actually I'm wanting to extend my skills, and what's your interest in regards to gynaecology scanning, and to just to be able to offer the best possible service at a primary care level. I think you don't necessarily need to be looking at very high specialist ultrasounds or MRI scanning, things like that.
Fantastic. I think we've covered some really great ground tonight. There's been quite a lot of questions come in earlier about the use of complementary therapies in endometriosis. The naturopath Jean Hales, Sandra Villela, has prepared a document which is available in the documents area, and it will be on our website as well. Just summarising some of the supporting research around lifestyle. Unfortunately, in terms of complementary therapies and evidence, there's not a lot of high quality evidence and randomised controlled trials that supports any particular therapies in endometriosis management. That doesn't mean that women won't be trying different things, and it doesn't mean that they shouldn't try different things. It's just that in terms of evidence, there's not a huge amount, but that doesn't mean anecdotally you won't have success, I guess, in helping with some of the symptoms. So there is a document that you can download, and in the ESHRA guidelines for the management of endometriosis, there is reference to particular studies that have been looked at in the development of that guideline as well. So one clinical pearl, and I think Melissa is the one to give it to me because she talked about it before, and then we really need to finish. I've got a couple more things to say.
I think listen to your patients. Women are generally busy. They're not going to bother going to the doctor unless there's something going on. And so if they're coming to you saying, I've got dysmenorrhea, I've got painful periods, I think, it means there's an issue. It means it's something that needs addressing, not just sort of patting them on the shoulder or telling them to go and get pregnant. You really need to explore that further. And it might not be endometriosis, but it might be an entree into other discussions such as, relationship difficulties or depression or, abuse situations. So I think, above all, listen to your patients.
Beautiful. As Mandy mentioned earlier, Jean Hales has got some fabulous resources coming out for endometriosis. They will be available very soon. When they're hot off the presses, we will be letting you know. So please fill in the evaluation, which you will find the link to on the tab above the slides. So please fill that out, subscribe to our health professional email. You will then hear about these resources as soon as they're available, and you can order them or download them online. So there's a booklet, there's a health professional tool, and there's a great brochure about periods for adolescents, which has the symptom diary, which everyone's advocated tonight. So thanks a lot for joining us. I think it's been a great night. There's been lots of questions, and we will do some of the frequently asked questions, and they'll sit with the webinar once it's in our library, which will be hopefully later in the week or early next week. And there's lots of links on the Jean Hales website for your patients, which look at link to other organisations and lots of resources that are available. So please get yourself familiar with that and join us again next time we have a health professional webinar. Thank you.